Hello, welcome to another session of our digital slide review and sign out, part of the Digital Anatomic Pathology Academy. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Medical Center, part of OU Health, as you can see from my background. Our case today comes from the realm of bone and surgical pathology. It's not particularly a diagnostic challenge, but I think in a somewhat unusual location presents an interesting differential for consideration. The patient is a 25-year-old woman who's had on and off knee pain, which became considerably worse after a recent stumble. Radiographs were performed looking perhaps for a fracture or some other sort of lesion. And as you can see here, her joint spaces are quite intact. The major bones, the tibia, the fibula, distal femur, all appear fairly unremarkable with relatively normal markings. However, as we look at the patella here, we can see that there is a degree of lucency, lytic changes, if you will, somewhat of a defined border around the edges with a little bit of peripheral ossification. Following up on this, MRI scans were performed, which showed that indeed the patella did not contain normal marrow, but had a more tissue-dense appearance in contrast to this on the fat saturation. This was not lytic here on the fluid saturation images, although there was some areas of possible fluid collection. So clearly something going on inside the patella that is probably pathologic and may account for some of the potential fracture-like changes at the periphery that could have been causing her pain. Well, if we think of tumors that can occur in the patella, there's really this rather lengthy list. On the benign side, we see giant cell tumors, chondroblastomas, osteoid osteitis, aneurysmal bone cysts, chondromas, osteochondromas, osteoblastomas, hemangiomas, and even primary osseous cysts. On the malignant side, you can occasionally encounter osteosarcomas, chondrosarcomas, and lymphoma or other disorders. So of these, certainly the most frequently encountered would be a giant cell tumor, which seems to appeal and be consistent with the morphologic appearance that we're seeing. But a primary bone cyst, not particularly compatible with the radiographic appearance, or other chondroblastoma type lesions possibly would be in our consideration. So in this circumstance, a biopsy was performed and a portion of the tissue was submitted for frozen section evaluation. Here is a low power image of that frozen section showing you scattered fragments. Now, I'll just mention here with regard to frozen section of osseous lesions, many times people shy away from this procedure, fearing that the bone will ruin their cryostat knives and so forth. But oftentimes you can select enough soft tissue or even tissue with occasional small bony spicules and identify the pertinent material to select for frozen section and make a reasonably accurate frozen section diagnosis. Well, as you've no doubt already identified at low magnification here, we see these scattered giant cells within the lesion, which is fairly cellular and includes a number of other cells along in the background as well. A little bit pink, sort of fibrotic appearing perhaps, and coming into higher magnification, we see that these cells have a moderate amount of pink cytoplasm, fairly uniform round nuclei, slightly oval, and they look not dissimilar from the nuclei of the giant cells that are scattered in a mix there. And so were it not for the giant cell cytoplasm, which is slightly more amphiphilic, we might think these are all the same cell population. And that has classically been referred to as the nuclear similarity between the giant cells and the stromal cells in these neoplasms. Now, on permanent section evaluation, we see again this same type of material, and a little bit better fixed and more eosinophilic and so forth, but not dissimilar from what we saw on frozen section. Now, having seen the radiographs in this circumstance, we can correlate this and recognize that this is not chondroblastoma. It is not a malignancy. We don't have any evidence of malignant osteoid formation. We certainly don't have much in the way of cytologic atypia. We might have a rare mitotic figure, and we don't have evidence of osteoid formation in any of the material that we're seeing here. Coming back to lower magnification, I think we can find a few areas where there is a little bit of bone formation, which you may get at the periphery of these lesions. But usually this is not malignant looking bone. It's sort of a reactive appearing bone, as you might see here, with a little bit of reactive changes, some osteoblastic rimming, some modifications here. So as the lesion tries to be contained, you'll get a little bit of eggshell type bone at the margin of this lesion. And that was evident in some areas on the radiographs, as you'll recall, toward the periphery of this lesion. Well, over the course of my career, we've learned a few things about giant cell tumor of bone. Of course, the radiographic and biologic behavior hasn't particularly changed. This is generally an osteolytic tumor that's quite circumscribed and most commonly affects the metaepiphysis, the epiphysis and the metaphysis. And usually this is in skeletally mature individuals, usually in their third, occasionally the fourth decade. The neoplastic cells are rather monotonous mononuclear cells, generally without any atypia, and are accompanied by numerous osteoclasts. We have learned, however, that these cells do harbor a mutation, H3.3 pGlyve34, and they will therefore be detectable using immunoagents directed at that mutation product. This is not something that's either widely available or in general widely needed, unless there is some other confounding or confusing aspect that may cause the differential to be clouded by the clinical presentation. These are rather elegant tumors to work with and kind of fun to see from time to time. I'll include in the digital slides linked to this broadcast a few additional examples for you to study under the digital microscope, as it were. But that really summarizes nicely our case for today. A patient with a giant cell tumor of bone. Oh, I do want to say distribution. Of course, we've mentioned that these are generally in the long bones and the metaepiphysis areas. But as you see here, the patella can be seen in up to 4% of cases. And occasionally in other bones like the ribs or scapulae, even in the mandible, you may identify this lesion, even occasionally in the vertebral column. So it's not entirely or exclusive to the extremities, though by far and wide the most common presentations are around the knee, sometimes in the shoulder or in the hip joint areas, the large joints of the body. So our final diagnosis today, giant cell tumor of bone, not a complicated diagnostic problem, but always nice to see an old friend stop by and show up on frozen section and be confirmed at permanent section. Well, if you like this, we certainly hope that you'll subscribe to the channel, hit that like button so that others will catch wind of this and have the opportunity to view these digital slides. As I mentioned, I post the link to the digital slides in the comment section, and look forward always to your feedback and comments. So until next time, thanks so much for joining me.